Our next speaker is no stranger to the public forum. She's Professor Lina Choong, and she's a senior consultant at the Department of Renal Medicine, Singapore General Hospital. She's the director of hemodialysis services at the Singapore General Hospital and the president of the Singapore Society of Nephrology. She is also the medical director and chairman of the medical advisory board of the Kidney Dialysis Foundation. She's going to tell us this topic on the RAS blockers, medications that retard diabetic kidney disease. Dr. Choong.
Thank you, Dr. Tan. I'm glad to see that all of you are still hanging there. It's a bit of a heavy-going topic, right? Okay. Now, before I start, I just, because this is a little bit complicated, I'd like to know, with a show of hands, how many of you are actually diabetic? Oh, that's why you're here. This is definitely more than the 1 in 10 that Dr. Jason Chu spoke about. Okay. Of all of you who are diabetic, how many of you have high blood pressure? Just a little bit less than just now, which is a lot of diabetics have high blood pressure. Okay, and of those of you who have diabetes or high blood pressure, okay, I'm going to now go to my slide. Can I have the first slide? Okay, how many of you are on RAS blocker? Nobody put up their hand. Not a single one. Okay, after I finish with my talk, maybe you tell me whether you're on a RAS blocker, okay? All right. This is a very, very common scenario that I get in my clinic, where I see diabetics and patients with high blood pressure. For those of you who can't read it, it says, Mrs. Lim, your blood pressure is still high. Mrs. Lim is a diabetic. You have been trying, in inverted commas, for a few months now to bring it down. I really must give you something for it. Okay, trying. Different ways of trying. Later on, you have the dietitian, Pauline, talk to you about diet. You had Dr. Kevin Tan just now talking to you about diabetes pills. Here, blood pressure, diabetes, very closely related. We'll see if we have any success with RAS blocker. Now, what does the patient say? Doctor, Mrs. Lim says, are you sure? I'm already taking 8 pills a day. Does it sound something that you would say? Right? A lot of the diabetics have many, many pills to take, right? And she's very reluctant to take another one. We need to prevent all the bad things that happen to diabetics. And Dr. Jason Chu have also already mentioned in great detail all the bad things that can happen to diabetics. You don't want to regret it later. I'm going to give you something called enalapril. Okay? Enalapril. Anybody on enalapril? Nobody shy, huh? Nobody wants to put up the hand. Okay. So what is a RAS blocker? RAS, renin angiotensin system. Okay? So what is this? A big mouthful of words. All right. This is a picture of the diabetic filter and a normal filter that's in our kidneys. Okay? Now this, I'm not sure whether this works, but let's try this one then. This works. Okay. So this is a filter. This is a normal one, and that's a diabetic one. We have about 1 million filters in each of one kidney. One kidney, 1 million. All right? And I just show you only one. Okay? You notice a few differences on these two pictures. It's like spot the difference. You know, when we were children, we always asked to spot the difference, right? Okay? So you see we have lined this in green. That's one. Okay? And there is also a lot more material in the center here compared with here. So a lot more material gets into the filter, And with time, it tends to crowd out these nice spaces. These nice spaces are actually where the blood will flow. So you can imagine that the blood flow will be restricted with time. Okay, and something goes on along this lining here that makes it abnormal. Okay, so these are the major changes when the diabetes affects the kidney, when it starts affecting the kidney. It's not like end stage kidney yet. Now, Dr. Chu showed you a very detailed chart of what happens in the diabetic kidney over time. And I show you a similar chart, just different color. I didn't go like one step at a time. This is just one chart. All right, there are two lines here in blue, this one going up, right? And this one going down. Okay, so what's that? And then you have it numbered 1, 2, 3, 4, 5. Then you have 5, 10, 15, 20, 25 years. Now remember, this condition goes over time. You're not going to see it at 1 year or 2 years. But a type 2 diabetic who has had diabetes for many, many years without knowing it, so he announces to everybody, I'm not diabetic. But if you went and tested his blood sugar, he could have been a diabetic, just that he never knew. So his story for him is 1 year. But maybe in his disease, he could have been 10 years. He's lost an opportunity of 10 years to get his diabetes under control and get his kidney treated such that he doesn't go into end-stage kidney failure. So what are these two lines? One is the function of the kidney, that's this light blue one going downhill. And the other one is the protein excretion. Okay, that means the leakage of protein going up. The higher the leakage of protein, it means the filter is damaged. Remember that green line I showed you just now? Okay, it gets thickened and it gets very leaky with protein. So protein is a hallmark of your kidney going bad. All right, the more there is, the worse it is. Okay, and when you start off with early kidney problem here, we can actually reverse it and almost bring it to normal. When you're out here, we can stabilize the problem. We might not be able to bring it down to normal, but we can slow down the process in which a patient gets end-stage kidney trouble. Right. It's very small here. Hypertension. That's why I asked you this question. Diabetic, how many hypertensive? It's very common. All right. By the time you have protein in the urine, you also have high blood pressure. And this high blood pressure is a constant stress on the kidney, and it can make your kidney problem progress faster and faster. And in fact, without treatment, the kidney will spoil very quickly. Now remember those holes I showed you in the filter? Well, this is a real microscope picture, right? This is the diabetic kidney, and this is the normal kidney. Again, spot the difference, but this is on the real, under the microscope picture. You see this filter here? What does it look like to you? It's very solid, isn't it? It's all filled. You can't see any space. Maybe a little bit of space around here, but that's outside the filter. But look at this one. It's got a lot of white in it. That means it's quite open, and that means blood can flow quite well through it. Okay, so that's the normal, and that's the diabetic filter. So patients who get kidney problem, very advanced kidney problem, the filters look like this under the microscope. All right? You can see a large picture here that comes from here. There's a lot of space here. See these nice big white areas? That's where the blood is going to go in. Okay, now, what does diabetes do to the renin angiotensin? I added an extra A here because there's aldosterone in the system as well. All right? Well, high blood sugar leads to a lot of hormone changes in the kidney. And endothelin is one. It's not a subject of discussion today. We've got this RAAS, and I've listed here renin, angiotensin, and aldosterone. Then there's a whole lot of other substances. Again, not for discussion today. What happens when you have this system activated? You get fibrous changes, you get filtration, hyperfiltration, and I'll explain that later. And then you have got hypertension and protein leakage. So these things happen to a diabetic kidney when you have a lot of high blood sugar levels. And that's why it is very, 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 very important, and this is definitely proven by trials, that if you control your blood sugar very well, you will have lower incidence of complications from diabetes. So diabetic control is very important. You're not going to feel any pain, okay? Don't wait until you feel something to control your diabetes. It's probably too late, okay? Maybe you have an ulcer in the leg and your big blood vessel in the leg is already blocked, okay? Your eyes, you are blind. No way you're going to rescue your eyes. So don't wait until that happens to you. And don't forget, that happens to you after 10 years or more of diabetes. You've lost 10 years in trying to control that illness. Okay? All right, this is going to be another chart, much like what Dr. Kevin Tan spoke to you about. The chart is in your handout, okay, if you want to refer to it, right? I'm just going to go step by step. It's rather complicated. Hope you don't fall asleep. But at the end of it, maybe some of you can tell me whether you're on an RAS blocker, okay? All right. The first thing that happens is that our body system has a natural way of retaining water and salt, or getting rid of water and salt if there's too much. Now, this RAS system originally is meant to keep our water balance in check. It's only one of the hormone systems. There are a few others. But for purpose of discussion, we are only interested in this for today. Okay? So remember, this is meant to keep our water balance and our salt balance in check. Okay? But in diabetes, this system goes out of whack. Something goes wrong with it. And that's why we have to use medicine that block this system. So how is this system helping us to keep our fluid and salt in balance? Well, there's something called angiotensinogen. Never mind this long word. Some pre-substance. It's found in the liver. And with the action of renin that comes from prorenin, okay, it acts on this angiotensin to give you angiotensinogen, a pre-substance, to give you angiotensin 1, and that's in the lung. Then with an enzyme, a substance called ACE, or ACE for short, you know, like the ace of spades, ace of clubs, ACE. It's actually angiotensin converting enzyme. So again, another mouthful, you may not be able to remember it. It converts 1 to 2. And it is the 2 that's very, very important for us. All these things are very short lifespan, but angiotensin 2 is the thing to remember. And we use a lot of drugs to counteract the action of angiotensin 2. Okay? Now notice that it seems to go in a straight line, like going down the main road. But, you know, you can take side lanes. So in the kidney, in our body system also, sometimes there's an escape. You know, got roadblock or traffic jam. So what do? You take side road, right? Okay? So in this, the body also very smart. You got blocked, there's a block here, so you took a side road. Okay, so what happens is when this happens, there's some sort of escape. And the angiotensin is still made, all right? Angiotensin acts on certain receptors in the body. So they go to the cell level and they stick to it on something called a receptor. There are different kinds of receptor. With this receptor, it will cause the adrenal gland that's sitting on top of the kidney to have this hormone called